Nice. Good evening, everybody, and welcome to the fifth session on this series on cystic fibrosis. And today we are going to talk about surveillance and monitoring and investigations in children with cystic fibrosis. Now, why this is so important is like we need to detect the disease progression before actually the clinical disease becomes or the clinical decline becomes very obvious. We need to give timely interventions, antibiotics, nutritional support, need to identify the complications, the CF-related diabetes, liver disease, improve the life expectancy, improve the quality of life. So all that is so important. We all know that it's a multidisciplinary care that CF needs. And this surveillance should be proactive, not just symptom driven, and regular monitoring is very, very important. And for this, I would like to introduce my co-moderator. He's very, very famous. Everybody like who are there in the world of uh, pulmonology, pediatric pulmonology, they all know him. He is Dr. Antony. Dr. Antony is going to introduce our speaker. So Dr. Antony is uh, he's done his MD, MRCPCH, and he's done his DA, DPSM, EDPRM. He's the chairperson of in the Department of Pediatrics, Consultant Pediatric Medicine at Coimbatore JKNM Hospital. He is famous because of his work in cystic fibrosis and in primary ciliary dyskinesias. He's got various medals and large number of publications in peer-reviewed and national and international journals. So over to you, Dr. Antony, to introduce our speaker today, and we're all waiting to hear from her. Thank you. Thank you very much.
Thank you, Dr. Pallab, for the kind introduction. And we have a very eminent speaker today. It's Dr. Supriya Shinde. She's a pediatric pulmonologist and a sleep specialist at Manipal Hospitals, Bangalore. And she has a special interest in cystic fibrosis. And she has been managing children with cystic fibrosis. And she has been involved in, multidisciplinary care, developing protocols in her hospital. And her work has been recognized internationally. And she was an invited speaker for this year's European Cystic Fibrosis Conference, and she presented her experience in that conference. And she is the very apt person to talk about this very important topic. I welcome Dr. Supriya to take over the session. Thank you.
Thank you. Thank you so much, Dr. Antony. Thank you, Dr. Pallab. I'm very happy that I've been given the opportunity to talk here with the parents, and I hope today's session helps. I'm going to start my talk now. Talk today is on investigation, surveillance, and monitoring in cystic fibrosis. And like Dr. Pallab said, I'm an associate consultant and I work at Manipal Hospitals in Bangalore. So the investigations for cystic fibrosis diagnosis is the first topic that I want to cover. That will be newborn screening. Newborn screening is not available everywhere in India. It's available in some of the private hospitals. But the goal is to make newborn screening available everywhere in India so that every child is detected early. The other test that is the gold standard for confirming cystic fibrosis is sweat chloride test. And then we also have the genetic test. So coming to the newborn screening, there is an enzyme called IRT that is when it's elevated, then that's when we say that this child is a child with suspected CF. And this test is done with a dried blood spot via a heel prick. It is done at birth to 2 weeks. And it is not valid after 4 weeks. So this is important to know that if the IRT is done, or sometimes if the IRT is high, a lot of centers might repeat an IRT before doing a sweat test or a genetic test, which is less available. So the repeating of the IRT has to be done before 4 weeks, before the child is 4 weeks of age. And then the IRT either as positive, negative, screening test, so there can be sometimes that it's elevated. It doesn't always necessarily mean that the child has cystic fibrosis. Sometimes it can be negative and they can still have cystic fibrosis. Then after a child is tested positive on the newborn screening for cystic fibrosis, then is referred to a CF center for a sweat chloride or a genetic test. So the next test that I'm going to talk about is the sweat chloride test. So the sweat chloride test is the gold standard. It's done earliest at 10 days after a child becomes 2 kgs or 36 weeks. And ideally within 1 month of age. That is the standard of care, that you want to recognize children with cystic fibrosis early. So you want to do it within 1 month. It can be done anytime when there's a suspicion for sepsis. So these are the values where less than 29 millimole per liter is termed as the test is negative. 30 to 59 is intermediate, where there's further testing and follow-up needed. And more than 60 is positive and is definitive for cystic fibrosis. So why the other test that is there is the genetic test. And in this, there'll be the genetic test where the CF causing mutations which are there in the genes, those will be identified. But if the genetic test is very complex to understand, and that's why it's very important that you are being seen at a CF referral center, because the child symptoms of cystic fibrosis and the genetic test doesn't pick up. There can be a lot of reasons. The lab that is there, is it a mutation that is recognized? The genetic test is negative, doesn't always exclude a diagnosis of F. So, and even if the genetic test is positive, it's always important to get a sweat test done to confirm the dysfunction of the CFTR channels. So these are the 3 tests that are important. And after that, the complexities of the tests are there. That's why it's important to go to a CF center. And, you know, the doctor is going to diagnose us based on the sweat test, the genetics, the symptoms, all of these things put together. A child will get, you know, a diagnosis of cystic fibrosis, confirmed cystic fibrosis, and that child will need a treatment and follow-up. Sometimes it can be that if the test was done, if the newborn screening was done and it came positive, but the sweat test is in the intermediate range, or, you know, there is one gene that is positive, then the child will be, you know, that child is labeled to have CFTR-related metabolic syndrome or cystic fibrosis screen positive inconclusive diagnosis, what we call CFSID, CFSID. So this means that the child needs follow-up. We cannot let the child, you know, just say that no, it's not cystic fibrosis and let the child be, because the symptoms can develop at a later point. So it's important to recognize early. So the parents must be made aware that follow-up is necessary. And during this period, you know, sometimes sweat test is a complicated test to do. It's available in very few centers in India. And the second thing is that the genetic test is expensive. So while we are waiting for the sweat test to be done or the genetic test to be done, and the clinical suspicion for cystic fibrosis is high, it is very important that we realize that the doctors, the treating doctors, start the CF treatment immediately, which is mainly the I'll come to it, that is which was discussed in previous sessions also, the Creon, the chest physiotherapy, the nebulization, all of this is started early. There is no time to waste. There's no time to waste once this is especially important when a child is diagnosed by the newborn screen. There's no time to waste and to wait for a confirmatory test. Once diagnosed with cystic fibrosis or a fecal elastase test is done, this test is a stool test where this enzyme elastase, which is there excreted from the pancreas into the stools, is tested for, and then the child is labeled as pancreatic sufficient or insufficient. It's not always necessary to do it. It would be ideal to do this test, but if the parents, are not, if it is an expensive test in the private setup, if you're not able to do this, sometimes a history of oily stools, large bulky stools, can be used as a marker that the fecal elastase is probably high and the child is pancreatic insufficient, indicating that this child needs the pancreatic enzymes such as creon to be given and started immediately. So the most important thing, once the child there's a suspicion for cystic fibrosis or there is a confirmed diagnosis of cystic fibrosis, is that you start the treatment immediately and emphasize that regular follow-up. So for parents, I want to tell them that the regular follow-up is very, very important. It's not just the first visit, it is multiple visits after that that are important at a specialized CF care center. So what is ideal and what is recommended is in infancy. So if a child was diagnosed by the newborn screening and then with a sweat test, genetic test, in the first 3 months, every week the child is followed up. And why is this? This is because we want to assess early the nutritional component. Is the child gaining weight or not? Because then we want to take more steps to ensure that the child is gaining adequate weight, that the chest physiotherapy is going on well, the techniques are well, so that, and the parents have understood how to use the pancreatic enzymes such as creon and the vitamins that are given along with it. So parents are called in every week for the first 3 months to assess all of these things and the weight. And between 3 months and 1 year of age, 2 to 4 weeks is ideal, because the weight gain and the technique of doing the the physiotherapy, the nebulizations, and the compliance, if the child is being given creon correctly or not, these all things are very important in the weight gain. And weight gain is a predictor of the how the child will do in the future. It is also very important predictor of how the lungs are functioning. So it's very important to monitor this child's growth regularly. And once post infancy, a 2 to 3 monthly follow up is important with your doctors. And I think in India, apart from physical visits, because in Manipal itself, we have patients who come from all over the country. So if it's not always the physical visits are possible, at least with the weight and the important whatever vitals, I'm going to say some things that are important to get these things checked at a local center, but at least via video consults, we should have a regular follow-up at a specialized CF care center. So each visit, the child should and the family should be seen by a multidisciplinary team. So that includes a pulmonologist. Okay, the pulmonologist is going to take the history, physical examination, look at the treatment that's been ongoing, or start a treatment after a cystic fibrosis diagnosis is made. And also seen equally important is the infectious disease, because in India, even within the first year of life, a lot of chest infections are common. And identification of the organisms and giving the right antibiotics for the right duration of period to eradicate the organism. The goal is always to eradicate the organism. So taking help of our infectious disease colleagues is very important. The gastroenterologist, who's also important, we do regular testing for the liver. Like there's some enzymes that are, there's some tests that are done annually. And after 3 years of age or 5 years of age, we also do ultrasound of the liver. And then the gastroenterologist also gets involved. Earlier, there are other symptoms. The endocrinologist to manage the diabetes and the bone health, and genetics becomes important, especially if a family or a couple who has a child with cystic fibrosis is trying to conceive another child. So that time the genetics involvement becomes even more important. And the nurse to check the weight, height, head circumference, and vitals, all of these things will be there. Respiratory therapist for sputum and cough swab sample collection. So in children who cannot produce sputum adequately, for younger children, we can do the cough swabs. And the respiratory therapist is also important for teaching physiotherapy and airway clearance. So every visit, the child should also be seen by a respiratory therapist, a dietitian who is guiding them on the diet chart, how much protein, how much calorie intake is going on, and how much fat intake is going on, how are they using the creon, does the creon the creon dose adjustment is primarily done by the doctors, but the dietitian is also helping the family understand how the capsules can be divided and what they're doing is right or not. Then a psychologist's involvement is extremely important for a new couple whose child has been recently diagnosed with cystic fibrosis, or for older children, adolescents who don't understand why, they always have this question, why them? They don't want to share it with their friends. So, and then they might not want to take the treatment. All of these issues come in time and again. So a psychologist should be available in most of the MDTs, most of the visits, so that the family and the child is regularly assessed. And respiratory physiologist who's going to do a pulmonary function test. So it's very important to get a pulmonary function test at all the visits. So what is the history that the doctor or the team, the MDT team is going to take when the child visits the clinic? So was there any history of cough, sputum production, wheezing, blood and sputum, physiotherapy routine that has been prescribed, nebulizations? Are they using any prophylactic antibiotics? Is the child on any oxygen or home ventilation? Are they going to assess for any ENT issues like difficult nasal congestion, or if there's any sneezing, so that also can be adequately treated? Apart from these regular clinics, visits that happen, as I've mentioned before, which can be monthly to, depending on the age of the child, can be 3 monthly. There'll be annual reviews. So during these annual reviews, we want to make sure, we want to scrutinize that what we have done throughout the year, is it right or not? Is it going in the right direction? Are there any medications to start, any medications to stop? Because children on cystic fibrosis are on so many medications, right? So an annual review where there's more time taken compared to each clinic visit, and looking at if the child has got the vaccinations, the flu vaccination, the vaccination for pneumonia, how many hospitalizations the child had in the last year. Was a bronchoscopy done, or is a bronchoscopy needed if the child is having, recurrent infections with the same organism, or sometimes is having symptoms but not able to produce any sputum to test for the organism? Then bronchoscopy becomes important. How many sputum cultures were done, and what was the results? What was their oral antibiotics requirement, IV antibiotic requirement? Were there any other organisms which can, make the lung disease worse, like tuberculosis or non-tuberculosis mycobacterium, and another organism called aspergillus? So all of these things, what I mentioned in the yellow box, is something that is annually we have to check, are we doing everything in the right direction? Then the gastroenterology symptoms. So this is also another part, they have talked about which all organs are affected. And symptoms. So if history, going at how meals, taking, dietitian is going to in deep taking, is a child compliant with the treatment or not? Vitamins that the child is taking, is the treatment, the vitamin dose, with increasing weight, there'll be a need in increasing the dose of the vitamins, and the creon is going to be, the dose is going to be adjusted. Initially, there'll be a particular dose that is started that Dr. Neha mentioned in the last talk, but based on the child's stool consistency and weight gain, the creon dose will be adjusted. Then the child's loose stools or constipation, we can explain about a stool chart so they are able to understand it. Any abdominal pain that is there, any symptoms of reflux. A lot of children with cystic fibrosis may have reflux where the food comes up and it irritates the throat, or there's some chest burning that is there. So these are the questions we need to ask at every clinic visit, and a parent should be aware of. And how is the weight gain going? The weight gain is one of the most important criteria to follow up in each visit. And if the child needs or is already receiving any supplementary or overnight feeds. During the annual visits, we want to look at, is the child requiring any long-term anti-reflux medications? Okay, and we have to reassess the need for these medications every visit. We have to look at if it needs to be started or stopped, if the child had any intestinal obstruction in the last year. The other thing we're going to look at is the compliance to chest physiotherapy, nebulizations, pancreatic enzyme, that is a creon intake, antibiotics that were prescribed, or the child can be on prophylactic antibiotics. Prophylactic antibiotics is when the child has, recurrent infection with the same organism, doctors might prescribe some antibiotics for a long term, or another antibiotics which can help reduce the swelling in the lungs or inflammation in the lungs, what we say. There's another antibiotic that can be prescribed. So the compliance to it has to be checked during each visit and the annual reviews. Then is a child on modulator. So the new treatment that has come for cystic fibrosis and is now available in India. So we have to look at what is the compliance to these drugs and how treatment, especially Creon, is taken when in school. So it is the responsibility of the multidisciplinary team, the doctor, the dietitian, to ensure that we are giving the child tips and tricks on how to take Creon when they're not at home, because at home, most of the children will take it. But at school, how do we reliably ensure that the children are receiving and taking the Creon? Because sometimes it can happen that the child doesn't want his friends to know that he has this condition. So he might not want to take the Creon at school. This is very common in the adolescent age group. So we have to ask and give them solutions. Then the surveillance, urine incontinence. So when children have persistent recurrent cough, they can be prone for passing urine involuntarily. And this is one history that is difficult to elicit, because a child might not want to tell it, an older child, or the parents might not realize the importance of discussing this with the team. So we need to ask for this. And we also need to regularly monitor, not only when the child crosses 10 years of age, even earlier. We need to ask for history during every annual review, at each clinic visit if possible, but at least once annually. From the starting, we need to ask if the child is passing excessive urine, is excessively thirsty. If the child is not gaining weight, why is this weight gain not happening? Is this because the pancreatic enzyme, that is the Creon dose, is not adequate? Or the child is having recurrent chest infections? Look at the pulmonary function test and see if there's a decline in the chest infections. And after all this, also you think in a younger child also, and especially in older adolescent kids, we need to look at their HbA1c and oral glucose tolerance test to look for diabetes. So this could be a reason for the child having weight loss. We need to ask for if the child has any bone pain, if has had any fractures in the last year, and also inquire about side effects of any medication. So we have the list of medications that the child is taking. So is the child having any abdominal pain? Is loose stool still continuing after taking some of the pills? Is the child feeling, or is it making him feel understand? So we have to ask about side effects of every medication that can happen, especially children who are on modulators. They also need to be assessed regularly for the side effects. Mental health, this is something that is often ignored, but it's very important to ask if the child is going to the school regularly. If not, why? Is it because the child is unwell, or the child has a low mood? And how much is the child involved in care? Is the child exercising? Is he going and playing outside? So these questions are very important. Then once the child is able to understand, we can always ask the child how the child feels, especially the adolescent, which my colleague Anchal is going to cover in more detail, but how they feel about the treatment. Are their friends aware or not? So I think questions around mental health are also very important. Physical examination at each visit is extremely important. We look at the weight, height, BMI, the overall growth of the child. Vitals like saturation and blood pressure are very important. Any signs of vitamin deficiency, which tells us the vitamin intake, like is the child's, what the vitamins that are prescribed, does a child need more? We are prescribing almost standard dosage by age that we follow, but sometimes is it the compliance good, or is it not enough? So you're going to look at skin changes, any vision changes. Is there any pallor? That is to if the child looks pale, so is there any signs of iron deficiency? And the other things is whether you would have seen when you go to the clinics that the doctor is looking for the fingers. It's not because if the nails are clean or not. It's mainly for something we call clubbing, which gives us an indication about the lung health. And then the chest examination, that is the work of breathing, chest shape, any added sounds. And then the abdominal examination and the ear, nose, and throat examination will be done by the doctor. The doctors also, or the chest physiotherapist, is also going to check for the nebulizer, inhaler, and the physiotherapy technique. So what are the monitoring and tests that are done at each visit? that is pulmonary function test as soon as the child is able to do it. This can be at around 5 to 6 years of age and older. It's very important to do this test regularly. Airway cultures. So for a child who's able to bring out sputum, that is kapha, then you're going to, test that for the culture and sensitivity and prescribe antibiotics accordingly. If a child is unable to bring out the sputum, even cough swab is a technique where, you just use a stick with a cotton in the end, which is a sterile cotton, and then the doctor is, or the physiotherapist is able to collect a sample by introducing it like a throat swab is able to collect a cough swab. It'd be good if the child is able to cough or coughs at that time, so that the lung, whatever the organism is in the lung, is reflected on this cotton swab and then sent to the lab. We need to do at least 4 of these cultures per year to make sure that the child is not having any organism in the airway. And if any organism grows, depending on the symptoms the child has, then we are going to plan for a complete eradication. If the child is not able to bring out sputum, a cough swab is not growing anything, we're not able to, but the child has consistent symptoms, not responding to antibiotics, then we need to do the bronchoscopy. Or if the child is falling, having regular chest infections, exacerbations, we need to plan a bronchoscopy to take good culture samples. Medication review should be done at each visit. This is very, very important because you want to make sure that the right dose of creon, vitamins, iron is going on if needed or not. Should we start any vitamin, stop anything? Inhaled drugs, should we start anything, stop anything? The antibiotics, if there any course that was given, was it completed or not? If the child is on any antibiotic prophylaxis, if the doctor has prescribed some long-term antibiotics, how is the compliance to it? Does it need to be stopped? All of these things needs to be assessed at each visit. If the child is on modulators, that is a new CFTR modulator treatment, then what is the compliance and how is it going? And we need to, if the child is using any anti-reflux medications, so is there a requirement still, or does any child need to be started on it? So this has to be assessed each visit. And like I mentioned already, the prophylactic antibiotics. So far what I spoke about was what is happening at each visit, what is ideal to happen at each visit. And then once a year, there should be, every child, once a year should have an annual review where everything is put together, everything is assessed together for the child. Like I already mentioned in my history and examination, those will be done at every visit. And there'll be some tests, even though the child doesn't have any symptoms, there'll be some need to pick up the complications and be able to treat it later. It's not difficult. So in bloods, we want to look at the complete blood count. We want to look at the hemoglobin of the child. We want to assess if the child needs any ferritin levels to be done, because we want to give iron therapy. Then the renal function test, the electrolytes, liver function test, very, very important to know, because as we know, in cystic fibrosis, the liver is also affected. So it's very important to do the liver function test. HbA1c is again for diabetes, to assess for diabetes. So this has to be done annually. Look at ferritin levels. This is again to decide if iron therapy needs to be started or not. In our setup in India, doing vitamin A, E, and zinc might be difficult. It might also be very expensive. So we don't regularly do it. But vitamin D, which is easily available, is something that should, the child is on vitamin D, but it would be a good thing to test this, if not annually, at least at a regular interval, depending on the cost and the financial capability, because then we want to make sure that, are we giving the correct dose? Do we need to increase the dose? Is it too much? Because when they're taking creon properly, and now that modulators are there, this is a box that is important. This is something that is ideal, especially now if the children are going to be on modulators. Like I said, the vitamins A, D, E, the monitoring of these vitamins becomes even more important. And it would be ideal to look for, growth of fungal organisms like aspergillus yearly. This is what is ideal. But especially if the child is having recurrent infections or wheezing, not responding to the antibiotics, it becomes even more important to check for the fungal organisms, or even the tuberculosis and non-tuberculosis mycobacteria. Imaging, we need to do the chest X-ray, and yearly once, that would be ideal. And abdominal ultrasound after 5 years of age. A DEXA scan, ideal would be around 10 years of age or earlier if there are any symptoms. And the CT chest is not something that is done regularly, but it depends on the clinical condition of the child, and the doctors will decide when the CT chest needs to be done, but it doesn't have to be always done like every year. The airway, we want to do the pulmonary function test, that is the lung test, where you must have seen that the doctors send you to, the doctors themselves might do it, where the child has to blow hard and fast. And this is done in children more than 5 to 6 years of age to look at how their lung function is doing. And the lung function assessment every 3 months, at least 2 times a year, would be very important, because sometimes the child is not gaining weight, but it doesn't have too many of the chest symptoms. And this decline in lung function is one of the first symptoms that can tell us that the child is having some infection that is going on, or some inflammation that needs to be addressed. So the lung function is equally important, and sputum culture sensitivity or a cough swab, like I mentioned. And we have to look for other rare organisms like Aspergillus, tuberculosis, and non-tuberculosis mycobacteria. Then urine analysis and BP, that is a blood pressure monitoring. The child is on steroids especially. And then hearing and eye check has to be considered annually. This is ideal, but depending on how the child is doing, but it should be done at least a couple of times. Like once in 2 years or once in 3 years, but it is something that we should consider doing it. And then oral glucose tolerance test. If there's suspicion for diabetes, HbA1c will always tell us. But at 10 years of age, even before the pre-diabetes, we want to identify the pre-diabetic state. So we want to do the oral glucose tolerance test. Then bronchoscopy and bronchoalveolar lavage. So like I mentioned, this is done at, again, it's not a thing that needs to be done like the CT chest at every year. This is done by the doctor decides it based on how the child has been through the year, responding, not responding to antibiotic treatment, number of chest infections that the child is having. A child who is having symptoms of chest infection but not able to produce any sputum, we are not able to grow any organisms, then we want to do a lavage, where we put a bronchoscope, that we put a tube inside the lungs and look at how the airways are looking, and then take a good sample from inside so that we can grow the organism and treat it with appropriate antibiotics. Then now, with the modulators being available in India, this is something very important for the doctors also, and for the families, to ensure that even before the modulators is started, eye check is very important. And after that, regularly for cataract, blood pressure monitoring before and after starting modulators, at least, there is, some things are done 3 monthly and some things annually. So obviously blood pressure at every visit is very important. Liver function, that is AST, ALT, and bilirubin, at least these to be done 3 monthly in the first year, and then at annual review, unless there is history of jaundice, there is recurrent abdominal pain, any other symptoms the child is having. Based on that, you can do it in between also. And with modulators, the other thing we have to also assess is the mental health and mood questionnaire. This is because sometimes some children, there are very few reports, but there are reports of children having low mood. So this is something that we need to assess. The rest of the topics under surveillance, that is CF-related diabetes, CF-related liver disease, CF-related bone disease, and the adolescent health, is going to be covered by my colleague Aanchal next Saturday. So I'm not talking on these topics today. And that was my last slide. And thank you very much. This is my email address. So if anyone has any questions, you can always reach out.
Thank you very much, Supriya,
Thank you,
for a very clear and very comprehensive session, and was very practical as well. I think we have now some time for questions and discussion. Are there any questions? Like the chat box, I couldn't see any questions.
No questions here.
Yeah, I would like to ask few things to Dr. Supriya. And one another important thing, at the time of diagnosis is this cystic fibrosis is a disease, it's a genetic disease. Therefore, it's a disease of the family. And what would you advise about testing for other siblings? Sometimes what happens is these siblings are missed out because initially they might be silent, and we had a couple of patients diagnosed a bit late, and there were serious illness for one of the kids, and the sibling had disease which was totally missed out. And other thing is genetic counseling for the families as well. If it is a first child, it's very important. What is your take on it,
Yes.
Dr. Supriya?
Child, tell the parents. I think there are two options we can provide to families. Is one thing is we tell the families about the symptoms to look out for. That the child can have it might not always be chest infections or abdominal, it might not be both together, it can be one of them. So we explain to the family the symptoms to look out for, or and they can come for a follow-up. Whenever they come for follow-up once a year at least, bring the sibling. Or the other thing that we can do is offer to do a sweat test, which is not very expensive compared to the genetic test, at least in some centers, and that will give us if this child is how much we need to follow up this. So this will give us a direct answer to that question. So I think sweat test also can be offered to the families.
Yeah. And the second important point you also touched upon is like this is a chronic disease. Cystic fibrosis is a chronic disease, and most of the treatment happens at home. They come to us at regular intervals, and you also insisted it's very important to come for regular follow because it's a chronic disease, not a disease that goes away immediately. And sometimes some parents are a little bit lethargic. They come whenever there is a problem, and here it's very, very important they have to come even if they don't have a problem, so that the child has a good lung health and a good longevity as well. And regarding the follow-up, what are the advice you give to the parents?
I
they
think
need to
there's
come
a
regularly,
problem with
and how will you motivate your parents there?
Sorry, sir, Dr. Pallab.
There are a few questions in by the parents. One
Okay.
is that how do we know a child is pancreatic sufficient or not? I think that was discussed, no?
So sir, for the parent who's asking that one thing is on history, the oily stools, the stool consistency, how many times the child is passing stools, and the test. It's especially when children are diagnosed through the newborn screening, so they might also not have developed the symptoms yet.
Right.
So it becomes very important.
Then somebody is asking that my child is 20 years old, has no problems. We've not seen any symptoms in him. What?
Yes.
Am I audible? This is a 20-year-old child, and I think the child is having cystic fibrosis. At the moment, he doesn't have any symptoms. And what should we do? Do we need to take all this treatment, or just the nebulizer and chest therapy enough?
So I think when the child, if the child is already on pancreatic enzymes, the fecal elastase test is a little bit difficult to understand. So this is something that I think it's very difficult to answer for me on the through a video. I need to know more history. And
I think it's better to consult their doctor, and it all depends on the type of mutation, whether the patient is pancreatic sufficient or not. Therefore, it depends on genetic mutation as well. Therefore, it's difficult to give a specific answer to this particular question. We move on to the next one. How to check lung function? What are the tests we have to do?
So for the lung function, lung function is a good non-invasive test. It doesn't have any risk of radiation also. So it's something that should be done regularly, probably 3 monthly is ideal. But if not, even at least twice a year, the lung function is done. So what happens in a lung function test is that there's a machine in front of you, and this is for children who are at least 4 years or 5 years and older, and the child is asked to breathe into this machine as fast and with the entire force they can. And there is one value in that is forced expiratory volume in the first minute that is assessed. And the doctors, based on this regular follow-up, when we do the lung function, we have a baseline and we do it every 3 monthly. We know that how the child is doing. Is it improving? Is it declining? And then we are able to treat accordingly.
Yeah. Therefore, lung function is a very non-invasive test. They have to understand that, and it can be easily done. Initially, it will be difficult. Probably they will be able to, get used to it. Therefore, it has to be done. And the next two questions are about modulators. This is a very important question actually at this juncture. And for the first question is, how much does the modulator cost? Okay. And the second question is, at what age we should start the modulators?
Okay. So I'll answer the second question first. What age do we start the modulators? So there are three types. Sorry.
Yeah, as the third question, I will ask. All CF patients eligible for modulators? That is an important question. Then we can. Yeah.
So first thing to start with, no, not all children are eligible for modulators yet. It depends on the genetic testing. So that's why the genetic test has become also very important now. Apart from the sweat test, the genetic test is important because it tells us if the child is eligible for the modulators or not. So that the answer to that will be only thing that you go to the doctor with the genetic test, the doctor's genetic test report. And the second one is the so modulators. What age? So there are three different types of modulators. One which is very popular right now, available in India, and two of the centers in India, which is an amazing thing that has happened. The Kaftrio, which has got three drugs, that is the Lexicaftor, the Tezacaftor, and Ivacaftor. So these this three drug combination drug is there. Initially, at least in the UK when I was there, it was available for children 6 years and above. But now it is the children about 2 years with appropriate genetics are also eligible for this drug. The other one, which can be started after 1 year of age, is something, the brand name is Orkambi, which has Lumicaftor and Ivacaftor. These are like two drug combination, which in India, I don't know if anyone is using this, but this is something that is in other countries, it's provided to children above 1 year of age. So my answer to that would be 1 for this 2 drug, and for the 3 drug about after 2 years of age. So what do you, Dr. Antony, any changes?
You asked about the cost of treatment. I think we have to inform them at the moment, there are 2 centers, ORDI and CMC Vellore, and the Vertex company is giving, the Trikafta medicine for eligible mutations, children above 6 years, through a compassionate program, free of cost. Therefore, you check with your doctor, and your doctor will guide you. It comes free of cost. At the moment, some of the patients have benefited because of this treatment. Yeah, you can also elaborate, doctor.
Yes. So the same thing that right now is available. Otherwise, the other way is there are 2 companies. One is the Vertex, which is very well known, and there's another Argentina company. I think the Vertex one, correct me if I'm wrong, I think it's if you have to buy it out of your own pocket, then I think it costs about 35 lakhs per month, if I'm not wrong. Please correct me. I'm not sure.
More than 5 lakhs. It's more than 5 lakhs. That's what I heard.
And
but
the
it's quite expensive. Yeah.
Yes. So the other,
I'm not sure about the cost. I'm not sure.
I'm sorry, I'm not sure about
They're
the
very
cost.
expensive. Yeah.
The company from Argentina, that is a little lesser than the Vertex, but these are the other options. But right now, CMC, Vellore, and Vadia, it would be a good option to go and enroll there, especially if your child is 2 years and above, and get the genetics also tested.
Yeah. And next couple of questions about, abdomen. And the first question is, how do we know our child is pancreatic sufficient or not? Yeah.
So this pancreatic sufficient or not, one is through history. If the child has oily stools, loose stools, large volume, bulky stools. So the history is one thing that we use to guide, because some of our patients can't afford the test to identify pancreatic sufficient or not is fecal elastase test. And this test is like the enzyme that is tested in the stool. So it's a stool test that is done to know if the child is pancreatic sufficient or not. And it becomes even more important to do this test when a child is identified early in the neonatal period, before even the symptoms start. No? So we want to make sure that we are giving to the creon to the child. And even some of the genetics of the child will tell us, depending on the genes identified, if the child is if even in the future, if the child doesn't have any symptoms or not, we are able to assess in the future the child will need creon or not.
Yeah. And as you said, like, it's important to do the test, stool fecal elastase test that will tell whether pancreatic sufficient or not. And other important point here is, like, even if your child is pancreatic sufficient in the first year, it's important to do regular testing. Over a period of time, they can become pancreatic insufficient. Next question is
I have just this question was always, I had this, is that in other countries, like we do fecal elastase regularly, but considering the cost that is there, would we use fecal elastase at all to monitor if the child's creon dose needs to be adjusted?
Sorry? Yeah, we can't rely upon fecal elastase to depend on it. So mostly on the growth parameters as well as the content of fat in the stools. Yeah. And next thing is, like, for occasional abdominal pain for my daughter of 25 years old, what is your advice, ma'am? Child is is a young adult having cystic fibrosis and having occasional abdominal pain.
Okay, so now need a little bit more history, how the stool consistencies, they're loose stools or constipation. So if loose stools are there along with that, then we will increase the creon dose. If the child is having constipation, then we're going to decrease the creon dose. We are going to assess if the child's abdominal pain is related to reflux, and then consider the child needs to be started on an anti-reflux medication. So these are the some things that I can think of. Constipation, assessing for constipation also is very, very important with a stool chart, understanding the kind of stools the child is passing.
And and the next question is about modulator. Madam, use of modulator is fine, but are we inviting more complicated issues like eye cataract or liver-related problems, etc.?
No, not at all. These are some things to monitor for. That's it. So, but the drugs are one of the most amazing, I think, discoveries, and we are very lucky as doctors, who are practicing right now, that we are able to use this drug, the 2-drug or even the 3-drug, the Captrio, the Trikafta, what Dr. Antony mentioned other names. These drugs are amazing. They're life-changing. So when I was in the UK for 2 years and the children had already been on these drugs for 2 to 3 years, it was amazing to see that children who needed BiPAP or oxygen or even lung transplant were out of these lists and doing very well with their lungs. Children who are not gaining weight or needed NG feeds to put on weight, they were out of all these treatments. In fact, the other things we are looking at, okay, is the weight gain too much? So I think, like any medication, you take a simple medication also, like a paracetamol, people are going to tell you about the complications because the doctors and the families need to be aware about it. But that is no reason to not take these drugs. Please go and register at Vadia, at CMC Vellore, enroll your child to make these drugs available so that a child gets these medications.
Okay, and this is regarding a 19-year-old, like adolescent having the patient doesn't have pancreatic problems. What advice is for me? 19-year-old who doesn't have cystic fibrosis without pancreatic insufficiency. What is your advice?
If it is the symptoms, the fecal elastase test and the genetics, all the three of them have ruled out ruled out that there's no pancreatic insufficiency, then it's okay not to take the creon. You need to do your other physiotherapies and the nebulizations and chest physiotherapy and the airway surveillance, like what I described. Those has to be done regularly.
Okay, and this is another question, very interesting one. And are there any red flag symptoms that need immediate attention and treated, and need to be treated aggressively? Red flags in cystic fibrosis, pulmonary and extrapulmonary, you can elaborate.
So I'll start again with the growth. Weight, very, very important. I think this is something that in the first year of life, even when I was in the UK and in India, medications are not available to children even in the UK. There is medication as in the modulator treatment is not available. And still the children there I see that the weight gain is not an issue. They don't have that many chest infections. And I think that is because of the aggressive nutritional management that is done right from the time of the newborn screening and the diagnosis of cystic fibrosis early on, aggressively, weight is monitored. Every checkup in the first 3 months, every week a child is caused for the weight. So weight, drop in weight or weight not increasing is one of the red flags. The second thing would be having recurrent chest infections. That is a red flag. The third thing would be, I think, if the child doesn't gain weight, doesn't look like is not having that many chest infections, but still the FEV1, if you're monitoring in an older child and it's dropping, then again, it's a red flag. With abdominal symptoms, having loose stools or having constipation is a red flag, because then it means that the creon dose needs to be adjusted. Anything, Doctor?
Yeah, I think one of the things I could remember is, DIOS. Some of your patients get DIOS. Please elaborate on that. Yeah,
So
please elaborate.
in cystic fibrosis, the underlying cause is that everything is thicker, like the secretions in the lungs, and then the enzymes are not adequately there to digest the food and in the stomach. So in simple language, so one thing is this children, especially in the when they're taking creon, also that the dose of creon should not adjusted and should be within the making the stools normal. It can happen sometimes that excessive dose can cause constipation, and taking less fiber in your diet can cause constipation, and not having enough water intake can cause constipation. So all these things and this long-term constipation that goes on, which is not addressed, loose stools and the oily stools, the family will easily, it's very easy to elicit this history, but constipation is something that can be missed out, and then the child can come with severe abdominal pain, vomiting, and with the symptoms of distal intestinal obstruction syndrome, which needs to be assessed for.
Yeah. And one more question we have, doctor, and this is a 20-year-old patient, cystic fibrosis, and who is on BiPAP and home oxygen, and she's awaiting lung transplant, and she requires frequent IV antibiotics as well. And she's asking what is the cost of PFT, and will I be able to do such tests? And finally, whether I will be eligible for the new combo drug medicines.
So to answer the new medication part depends on the genetics. So you need to go back to your doctor and look at the genetics. If you have not done the genetic test, do the genetic test, and then means under the guidance of your doctor, because it has to be an appropriate genetic test. So when I mean genetic test, the doctor will decide the appropriate, because there can be sometimes some panels which you miss out on cystic fibrosis. So very important to go to your doctor. Please just don't go to any clinic or any of these labs and just get a genetic test done. And based on the genetic test, the eligibility will be decided. The second question was PFT, so pulmonary function test.
Yeah, pulmonary function test.
The cost for pulmonary function test, I think, varies from center to center. Obviously, in a government setup, it's going to be much lesser. In a private setup, it can be anywhere between 1,500 to 2,000 or more, I'm guessing.
Yeah, around 1,000. Most of the tier 2 cities is like 1,000. If it is 1,000. A big city,
in Manipal, I think it's 2,000, so or 1,500.
Yeah. And the other thing, I just wanted to ask you is one of the neglected things is, as you said, on mental health, not only of the patient as well as the family. And second thing is, infection control. Most of the times, infection is something invisible. Like when they come to the hospital, important to wear mask, and they have to take care about hand hygiene, while at home important to clean the devices and everything properly. What is your advice on that actually to the parents?
Definitely, sir. So one thing is that when you go to first things,
just infection control.
So infection control, sir, first thing at home is again hand hygiene, like you mentioned, sir, and when you're going out, especially to the hospitals. Second thing, at home, I always it becomes the machines that are there. It's very there's so much treatment burden that is there for these families, that the regular cleaning of the nebulizer machines, and all of it takes a second place. So your inhaler devices, like we say, once a week. Similarly for your nebulizer machines, and if you have BiPAP, according to the instructions, the device that you have, cleaning the filters, cleaning the humidifiers if it's being used, all of these things is something that you need to ask your doctors and make sure that you're following it. When you come to the clinic, it is very important, and it is very important for doctors and to do that, as you know, hospital, this thing that we don't mix our children when they're waiting for, a cystic fibrosis clinic. Ideally it would be nice to know you to see these children on different days, and if there's a clinic on a particular day happening, we need to keep them in separate rooms, not allow them to mix with other children, because then they can transfer these organisms to each other. And the third thing is, once Staph aureus, especially this particular organism that grows, this is for the doctors, that we should advise our families that they change their toothbrush, after the child is treated with the antibiotic course, because that again becomes a source of the infection. So these are some of the few things I can think of right now. So
one thing I wanted to ask you, Supriya, is now we have this FOT and IO. So many of these younger children, if they can't do the PFT, can we advise that? And is there any guidance regarding that? In place of FE, one can we do the FOT or whatever?
So I'm sorry, not at all. Means I've not. We don't. We don't use
Yes,
FOT
yes.
when I was in the UK, and even here at Manipal, we are not using it for our cystic fibrosis children. So we're using clinical symptoms and the airway microbiology itself. I'm not sure about this. Should we be using FOT, or how? What are the how? But I think we can monitor the similar way depending on the first FOT and then follow up. It's more for, I think not one value is important. It is also the subsequent values and the comparison that it becomes important. So we need to see how that can be done.
And the other good thing about it is that there is a filter. So the chances of spreading infection, is much less with that compared to this
What
enormous
has
virus.
been your experience, sir? Like we
Yeah,
obviously have
same. We if younger children, no. So I do the FOT and then we'll repeat it and see that is
repeated
it better, it's worse. So we don't have a standard, but we can use the child standard to
monitoring.
Monitor.
Yes.
Okay, then there are no questions. Dr. Pallab, is it okay if we can close the section?
Yeah, I think so. I think it was a wonderful session. Everything was taken care of, answered so well. There's nothing to do. Excellent session. Great.
Yeah. On behalf of everyone here, I would like to sincerely thank Dr. Supriya for sharing her expertise and practical guidance. And I will like to thank ORDI for having organized this meeting in a very nice way. And I would like to thank the audience for their active participation, very stimulating questions as well. And I think it's a teamwork, and as most important person of the team in cystic fibrosis care is the family. I think it's our duty to educate, empower them, and motivate them as well. It's very, very important. And it's a very difficult race, and we are there to support all of you. And together we can ensure better care and brighter future for every child with CF. And I think with the advent of these medications and availability of the medication in India, and things are going to get better. Pallab, what do you think? What is your final closing remarks?
Yes, absolutely. So I think we have a brighter future for these children. If these things get available, and if other parties come up and help them with the finances, then it's going to be wonderful actually.
Thank you. Thank you.
Thank you so much.
Thank you very much. Thank you.